Conway Hall, London, where ethics matter.
Welcome to Conway Hall, where ethics matter. Conway Hall is a membership organisation and educational charity with an over 2 centuries long history. That makes it the oldest surviving free thought organisation in the world. Please donate to us if you possibly can. We'll use your money very wisely to host talks, concerts, exhibitions and events to promote discussion and free thought. We also hold the largest and most comprehensive humanist research resource in the form of our library here, so we may end up spending some of your money on books too. Christopher Thomas is at the heart of research and policy in health in Britain. He has a background in epidemiology and he is a senior research fellow at the Institute for Public Policy Research. He's the co-editor of the Progressive Review, which is a journal of ideas and politics. He's led on public health and inequality at major charities, including Macmillan Cancer Support and Cancer Research UK. Our recent history with COVID has exposed the limits of neoliberal public health orthodoxy. But is the left stuck in a rearguard action focused on defending the NHS from privatisation? Christopher Thomas argues that we must emerge from COVID on the offensive, with a bold new vision for our health and care, a radical expansion of the principles on which the NHS was founded. You can buy his book, and the link is available, should be on your screen right now. His book, The 5 Health Frontiers, a new radical blueprint, is available. Welcome very much this evening, Christopher Thomas.
Brilliant, thanks very much. And it's great to be doing something in person, a hybrid event. That feels like a very big privilege after Omicron and the kind of couple of years we've just had. And to be talking as well about public health feels brilliant as well. Thank you to everyone that's joined online too. What I'm going to do is I'm going to talk through public health and the 5 health frontiers in 5 stories. So 5 stories that indicate some of the arguments that I put forward in the book. Hopefully they're interesting, but most of all, hopefully they're slightly provocative. I think one of the core purposes for this book is to try to drive ideas and debate in public health. I think when I was coming into the 5 health frontiers, one thing I was very conscious of was that compared to the climate movement and the new economy movement, other vibrant sources of progressive thought, public health sometimes doesn't have that same kind of ambition in terms of how it's talked about. And I think one of the big purposes here, one of the things that we desperately need, having had a public health emergency, something that happened to the 2 movements I've just mentioned, New Economy, Green New Deal, after their crisis in 2008, the financial crisis, is that kind of aspiration. So it might not be that we all in the room agree on every idea, but hopefully we can have a good conversation about them and refine them and use it as a starting point to think about what, after COVID-19, the settlement, the consensus looks like on public health going forward. So I wanted to start today by talking a little bit about George Orwell, or Eric Blair as he was then known, so the first story today. And George Orwell in 1928, February 1928, travelled to France. He travelled to Paris, and that wasn't an unfamiliar trip for people of his profession. There were lots of contemporaries at that point living in Paris. He was amongst good company, Ernest Hemingway, Gertrude Stein, T.S. Eliot, all part of the generation that moved to France from the US. Except George's experience was very different. So whereas his contemporaries were well known for the hedonism of the cafe culture of 1920s, 1930s Paris, George Orwell had an experience tainted by serious health concerns. And shortly after moving to Paris, he developed a horrible respiratory illness. Of course, we've had our own experience with the damage that respiratory illnesses can do. In this case, we don't know what disease it was, but we think it was probably pneumonia, but that's not certain. And that took George away from the cafes of Paris and into the hospitals, or specifically l'Hôpital Cochin, a hospital that still stands today, albeit a much better reputation than it had in the 1920s. So George Orwell was obviously very impacted by this story. It runs through some of his non-fiction essays and some of his semi-fictional accounts as well. So it's the basis of the story down and out in Paris and London. But more significantly for us, I think, it's the basis of the seminal essay, How the Poor Die. In How the Poor Die, he documents his experience of the hospital. He talks about arriving with a temperature well beyond what a fever would look like, delirious with pneumonia he was experiencing, to be interviewed for 20 minutes by a stern hospital receptionist. He talks at length about how he's put into the uniform of the hospital, so a loose-fitting gown, a pair of slippers, and walked across the open courtyard in February in Paris with suspected pneumonia, not the best course of action maybe by modern standards. He arrives in a hospital where the beds are 6 inches from each other, where people are stacked in, where, to use his words, the smell is feces and sweetness, a horrible combination of bodily fluids that people around him have amalgamated. He watches, not the pay-as-you-go TVs that we associate with our own hospital wards today, but people next to him having procedures carried out on them. One man has cupped a procedure where they flame in a cup to create bulbous yellow blisters, which they then drain into the bucket next door. It is a horrific experience of a hospital that in the 1920s of France has more to do with the prison or the torture chamber than it does with anything that we'd see as socially just, as forward-thinking, as progressive. Now, George Orwell releases How the Poor Die in the 1940s as a groundswell of thought is starting to move away from the idea of a two-tier system of hospital care that had seen before and into the kind of arguments we see for a universal health system. But the important point about the release is that he is documenting the difference in that public hospital ward, which would only have been something that was really there for the poor of France. England slightly better, but still not great. Whereas the rich would have taken private hospital rooms at the very worst, and much more usually, they'd have had their hospital care come to them. They would have had their doctors deliver their care in their own home. And what we see is that Orwell writes at a time that there's a groundswell for universal healthcare, and we see in England the great humanising achievement of the National Health Service, free at the point of delivery based on need. One of the greatest formulas that we've come up with for the delivery of health interventions, for welfare interventions, something that sustained popularity and has broadly had universal support from the British public since. It's an intervention that does a couple of things, but I think most significantly, it starts to convince some that healthcare has been fixed, that we've kind of done it on the health agenda, that we now have equality because we have a welfare institution. It now has a budget of 160 billion. That's 160 billion that's delivered on the principle of democratic socialism, on the principle of free at the point of delivery based on need. And so we come into COVID with this institution and this sense of equality, and you can kind of see how that changes the commentary that we see in March of 2020. In March of 2020, there's this great thread of we're all in it together. COVID-19 has broken out, and you have the Evening Standard declaring London stands together. You have John Harris in The Guardian talking about how the difference between the shirker and the striver matters no longer because we're facing this grave pandemic. Madonna, the singer, delivers a message from her bathtub with rose petals where she talks about how we're all in it together. Arnold Schwarzenegger delivers a message on YouTube to his fans from a hot tub in his California mansion, smoking a cigar, saying, we're all in it together, we're all facing this burden together. And actually, when the data started to come out, what we saw was we weren't all in it together. That narrative, as much as it kind of showed what people had intuitively thought would happen, some of those preconceptions of health as one of the agendas where equality has been secured, actually the differences in outcome were incredibly stark. We saw that occupation was one of the most fundamental drivers of your risk of catching COVID or of dying from COVID. We saw, according to research by the Institute for Public Policy Research, that the risk of COVID if you were white or if you were black was fundamentally different, to the point that if white people across the country had had the same risk of death from COVID-19 as black people, 60,000 more people would have died in the first year alone, when the death rate was much lower. A fundamental discrepancy in what was going on that I think provides some fundamental proof that for the humanising advances that we've had in the last 70 years, we haven't completed the job on health by any means. There is still core inequality in how health is distributed. And if we think about, I think, health as a distributive system, okay, so if we think about it in the way that we might think about the economy, what we'd surely see is that the size of the pie when it comes to health isn't being maximised. What you might say was, in economic terms, the total wealth. Well, in this case, the total health is not as big as it could be. But even more fundamentally, a problem is that that is not distributed in any way equally. And we shouldn't have been surprised in some ways when COVID-19 hit, because the truth of that in the data has always been there. So if we look to where we were even in 2019, what we see is that we can go into cancer or mental health, diabetes, any other condition almost that you care to mention, except maybe those that hit really late in life on average. And we can see fundamental inequalities. We can see it in longevity. It's often remarked, isn't it, by politicians, the great inequality of someone born in the richest part of the country can expect to live 10 years longer than someone born in the poorest local authority. What we actually know now is that if you break that down to an even smaller level, not local authority, but perhaps neighbourhoods, that inequality is 30 years. So a 30-year life expectancy gap between people on the basis of income still exists in this country today. So we needn't have been surprised when COVID-19 hit. And I think the question we have to ask ourselves then is, given this, given what we've just experienced, a pandemic that showed us huge inequality, that didn't create that inequality, but now has shown us at unignorable scale how extensive that inequality is, we need to start thinking about whether change now comes and what that change looks like. How can we take up the mantle, having been shown the demonstrable evidence, the kind of evidence for our times, that surely akin to the kind of things that George Orwell saw in L'Hôpital Cochin? What do we now do in terms of change? The imagination in the 1940s landed on universal healthcare. The opportunity now for us is to think about what change we take forward. I think the conditions for change seem to be in place. And there are two things that give us confidence that change is likely to come, I think. The first is the evidence. I mean, the evidence is entirely compelling. There is very few other agendas that have the same level of evidence that we have in public health that things are going a little bit awry in terms of both the justice and the total health of the population. Very few can talk to that level of certainty about the fact that that exists, that inequality exists. In other places it's more debatable, and why it exists. So we have that to our advantage. But even more importantly, we have crisis. And crisis is, in almost all theory, the key prerequisite for change. So we can look at some of the people that have theorized that. We can say Karl Marx is one thinker that suggests that change is a prerequisite for change is crisis. We can look at Milton Friedman, who declared that the job of the think tank, of the academic, was to keep ideas alive just as long as they could wait for crisis, because that was the opportunity to breathe life into them, to bring them into implementation. John Kingdon, another thinker, William Beveridge, another, all who suggest that crisis brings change. Or we don't have to look at thinkers, we can look at the history of pandemics, and pandemics, more than surely any other crisis, are the vehicle in history for change. We can link a number of kind of massive human changes to the experience of a pandemic, or at least a major infectious disease outbreak. So there's now very compelling evidence linking infectious disease outbreaks to the French Revolution, to the Russian Revolution, to the rise of the Nazi Party in the 1930s in Germany. The Spanish flu, one of the more understated factors, we all focus in school, don't we, on the Treaty of Versailles, but the Spanish flu, a huge determinant of the socioeconomic structures of the human experience that led up to Hitler's rise to power in Germany. So pandemics are surely well beyond that criteria for change that those thinkers that I've mentioned talk about. And we can see that ourselves, can't we? Because if we think about the crisis we've experienced, well, the pandemic has the social impact of an industrial revolution, the human impact of a war, and the economic impact of a financial crash. So well beyond the threshold that we'd surely need to see for change. So we know that change needs to come, and we know that we have some of the conditions. We can expect change potentially to happen. But I think we need to be cautious in some ways, because one of the mistakes I think that can sometimes happen in progressive strategy is seeing change as always a battle between progress and the status quo, a challenge to push the status quo forward. But the thinkers that I've talked about, Marx, Friedman, Beveridge, Kingdon, those four come from hugely different backgrounds of thought. You have a Marxist, you have a neoliberal thinker, you have Beveridge, a liberal MP and then later a liberal lord. You have Kingdon, a high kind of profile academic. And what's interesting there, I think, is the implication that change will actually be heavily contested. It could be that if we think about what comes after the pandemic on public health, we have something fundamentally good. We have a reinvigoration of the NHS. We have action on the inequalities that we've seen play out so alarmingly during the pandemic. Or things get worse. We have a more libertarian switch in how we approach public health. We see reform trajectories in the NHS go even further into the competition, marketisation that we've seen in the past. We see social care unfixed or worsened through greater involvement of private equity. There are trajectories here that are not as positive as we think. Change sometimes often tends to be more on the progressive side. So we have to think quite carefully, I think. And I think we have to think about, one, what the compelling vision is for the future, and also how that relates to our strategy. What are we trying to achieve? How are we going about the change that we see? And I think that probably challenges us to think about two ways that health activism, health thinking, has sometimes not been at its best, that it isn't as optimized for change in the 21st century as we'd like it to be. And I think there are two dynamics to that. Okay, so the first is that when people campaign, talk about, create new ideas on health, they're often an affliction that I call in the book, an NHS centrism. So with the advent of the National Health Service in the 1940s, we see a very clear change in how we think about health. If we take the 1919 Ministry of Health that was formed under the Lloyd George regime, what's really interesting about that is that that wasn't about hospitals predominantly. It was about air pollution. It had control of the poor laws. It had control of housing, local government, things that we know are kind of health critical, but much broader than just health care. But when I think we talk, or when campaigners, thinkers, policy people, politicians, journalists talk about health, we sometimes make this leap to say that health is healthcare, is hospitals. And you can see that in the kind of policy decisions that are made, can't you? You can see that in how funding is allocated. You can see that in the sheer size of the NHS. You can see that in terms of what gets people to walk through the streets of London in their tens of thousands, backing, calls for better health. Healthcare has become the key lever in how we can improve health. It's become the only lever that we can see on our horizon to improve health. And that's a problem, because actually 80%, maybe 90%, depending on the study, of the inequality that I talked about at the start of this talk, that's down to everything except for the healthcare service. So we're artificially limiting, by being very focused on the NHS, through our love of the NHS as a society, the levers that we have available to us to improve the health of the population, to forward new advances, new frontiers in terms of the public health settlement that we have, to prepare for shock events like pandemics. So that's NHS centrism. I think the other thing that we have is, and this ties together, is what I call the spectre of the sell-off. We are scared that the only route to regression in terms of healthcare and health, population health, is privatisation of the NHS, that's the way in which our health is going to get worse, that's the method through which our health is going to be destroyed. And based on that, and you can see it's a really kind of continuous story, isn't it? A remarkably continuous story, particularly on the left. In the 1980s, it's denationalisation. 2019, it was an American trade deal. Today, it's the Health and Social Care Bill that's going through Parliament. All of these generate campaigns that are against privatisation. But all of these suggest, I think, that the NHS is under fundamental threat. And they push us, again, to focus on thinking about how we can serve the NHS, the great bastion of equality, the kind of embodiment of democratic socialism, right? And instead of thinking ambitiously about going on the offensive, we become, many of us that love health, many on the left, the small c conservatives. We're the people that are trying to maintain a status quo based on a brilliant healthcare service without ideas for what else needs to follow. So that's the challenge we find ourselves in, I think, is one where we don't have movements, activism, politics, discourses that are entirely well optimized to the realities of health as we find them, the realities of health as they were exposed by COVID-19. And that's where I think we need a fundamental difference. Of course, that doesn't mean ever being anti-NHS. I think, and talk about in the book, that revitalizing the NHS is one of the most important things we can do in terms of its capacity, in terms of its funding. But we also have to think more broadly, and I think create campaigns and ideas that are based on things that exist outside the NHS. So for the rest of this talk, what I want to talk about are four of the ones that I talk about, four further stories that kind of start to indicate where we can advance the principles and progressive health ideas that aren't just healthcare, that talk to the other 80-90% of what drives the massive, massive inequality that we see in health today, that drove why COVID-19 was such a shock and went so badly for us as a country. And I want to talk about those in a way that doesn't necessarily kind of broach on healthcare too much. So the beyond hospital movement that we can create for ourselves going forward into the next coming decades. So the first one that I want to talk about, and the second story that I'll tell today, is about the social justice frontier, as I call it. And the story that I want to open that with is the one of Charles Dickens' A Christmas Carol, one of the most told stories in books like this, I'm sure. And particularly the experience of Tiny Tim. Now, Tiny Tim is really interesting and actually has generated huge amounts of academic literature, clinical academic literature from medics who have been desperately searching for what on earth it was he was sick with. Something clearly fatal, something that would definitely have killed him in one of the timelines, but that a little bit of generosity and improvement in pay on the part of Ebenezer Scrooge, that's enough to save his life. So what strange condition is this that an increase in social conditions is enough to save Tiny Tim? And the explanations have been multiple. So some have suggested tuberculosis, some rickets, some combination of the two. Tubular acidosis has been proposed by one academic. And in many ways, actually, the search for that specific diagnosis isn't that important. What's really important is the realization that we've had in searching for it, that it was the social conditions that Tiny Tim lived in that were making him sick, that were fatal to his life. There was no lack of access to the NHS in Tiny Tim's story that would have made a difference. There were no, at that point, antibiotics that could have been prescribed. It was fundamentally about the conditions in which he lived. And we can think about what some of those were, right? So we can think about the smoky, squalid house. Tiny Tim's house is based on Charles Dickens' own, a Camden hovel that he described as wretched with mud. And we can also think about the employment, the lack of pay that his dad experiences. We can think about the nutrition, the very slender meal that they have on Christmas Day, indicative of further problems with malnutrition. We can think about the inability to exercise, the air pollution, the smog of Victorian Britain. It was the squalor he lived in that made him ill. It was the improvement to that social condition at the end of the book that saved his life. Now that's interesting because we can trace Tiny Tim as a character to millions and millions and millions of people living in Britain today. Many, many people experience, in many cases fatal, in other cases very unpleasant, health conditions as a pure result of the social circumstances they find themselves in. We can take two, maybe as just case studies between us. We can think of the housing question. Well, overcrowded housing was one of the big vectors for COVID-19, but it's also a continuing risk factor for tuberculosis today, one of the most important factors in driving that condition. We can see that from the government's own literature, 1 million people live in housing with a Category 1 hazard. And a Category 1 hazard could be asbestos, could be carbon monoxide, it could be mold, it could be black fungus, any number of appalling, dangerous things that can drive ill health. Or we can think about employment and the kind of experiences that Bob Cratchit had that in turn impacted his family. We can see today that many, many people are in conditions of precarity that have direct and heavily evidenced impact on their health. So we know from recent literature that the piece rate style of work often seen in the gig economy is fundamentally linked to worse health outcomes for people that have it compared to salaried workers. We know that from the Michael Marmot Whitehall studies, and have known for a long time, that those that are in the highest grades of the civil service live an extravagantly longer time in terms of total lifespan than people in more junior administrative ranks. Of course, we know that the gig economy from Ursula Hughes's remarkable work across Europe is linked to worse occupational health, worse mental health. And we know that that's a racialised injustice because there's a continuing link, for example, between stress, discrimination, and heart attack that particularly impacts black women today in our country. Avoidable deaths, avoidable disease, in every bit descended from the kinds of conditions of Tiny Tim in Victorian England, the kind of conditions that I'm sure many of us thought were residual to the past. Injustices we're not always necessarily conscious still exist today. When we're thinking about Tiny Tim's story, I think what we realise as we trace that through to the modern day is that Bevan's work in setting up the National Health Service was only half a job. If we think about the kind of trajectory that people go through when they have a health condition, yes, they go to their GP, maybe they get a diagnosis, they get some care or some treatment. They might then go off into some aftercare or potentially end-of-life care. But what we forget in that pathway is a whole swathe of things that happened before. People exist in places. They experience socioeconomic factors on their life. They experience behaviours that are predetermined, we can see from the evidence, by the kind of material conditions of the place they live. Their reaction to a symptom is going to be preconditioned by the place that they live, both material and cultural. There's a whole swathe of that pipeline that isn't free at the point of need services that we haven't intervened in. And so the first part of the radical new blueprint in the book is a universal public health service. Why is it, as a fundamental question, as a society within the welfare state, that we're happy to collectively fund cancer treatment or a course of antibiotics, but when we know that something like housing, or a good education is a fundamental predictor of a healthy life, we're not willing to put that on the same basis of free at the point of delivery based on need that we see in the NHS, despite the fact that the evidence is fundamentally good, that that can improve health and that that can have a knock-on massive benefit to the economy, to tax take, to all kinds of things that we think are important in other discussions. For 40 billion, per year, it would be possible to deliver a universal public health service that offers fundamental guarantees to a healthy life for everybody on that basis of free at the point of delivery. That could be an improved education prescribed to those that need it by people in their local community, building on the work that directors of public health already do in terms of that place-based approach. That could include income, a UBI-style approach to the interaction between low pay and problem debt and health problems. That could include nutrition, building on the work of Marcus Rashford and the more recent campaigns we've seen around kind of value ranges and the impact of inflation. A nutritious, sustainable food offer for everyone that needs it, again, delivered free at the point of delivery based on need. A build on the Healthy Start vouchers that we know are so impactful otherwise, but a much bigger expansion of that policy. So we can start to see that there are ways to expand the kind of radicalism in this case that Bevan talked about, but we can expand it to a much more modern understanding of health, to the kind of drivers of inequality and poor health that exist today, that are the biggest priorities for society as it exists today that we saw. Learn the lessons of COVID-19 as we seek to do that. So that brings us to the next story, which is one about, I suppose, the other side of this equation, but a story of tobacco. And there was an interesting movement in the let's say the first half of the 20th century, whereby doctors had begun to notice a spike in lung cancer. And they launched an urgent investigation for the cause. And eventually it was researched by Richard Doll that showed, working with doctors, that it was tobacco that was at the heart of it. Now, we've known for, quick maths on the spot, 70 years, that tobacco is a fundamental driver of many causes of cancer, chief amongst them lung cancer, the cancer that is most at the heart of inequality, one of the most fatal. And yet, we still stand here today in a period where tobacco companies are toasting vintage years. This year, dividends for many of the biggest tobacco companies in the world went up. They toasted record profits in many cases, driven by global expansion, often not the most ethical kinds of global expansion that we could think of. And what's interesting about that story of tobacco is that I think the kind of sheer audacity of the tobacco industry, who are well known, who have had best-selling novels written about them for the kind of lobbying techniques, underhand tactics, an industry that has been linked in some countries to creating their own black markets to undermine government regulation. We're pushed to see health exploitation as something I call the bad egg fallacy. That it's only individual, a small number of individual sectors, probably sectors where they produce very unhealthy products, tobacco, alcohol, increasingly big food and drink, ultra-processed food. We're tempted to see health exploitation as a problem of those individual sectors, when actually what we should see is that health exploitation is a function of the core economic model that we use in the country and most of the Western world today. Sorry. So we have a model of growth and of our economy that fundamentally encourages health exploitation at the expense of the individual, of us, and in the interest of capital. And there's a story, metric, a story of a data point, a story of a metric that tells this very well. And that's a story that's been well told by the sustainability and the climate movement, but it's about GDP. Now, GDP does three really important things. First, it values every activity that makes us sick at expense of profit. And that can be a range of things. That can be the production of alcohol or the exploitative marketing of ultra-processed food, particularly to children. Or it can be the same things that we saw as the cause of Tiny Tim's illness earlier. It can be bad bosses. It can be rentiers, it can be bad landlords, not fixing their tenants' homes, those awful Category 1 hazards, in the interest of maximising profit. So that's the first factor, is that is valued disproportionately in the GDP measure. The second thing that it does is it overvalues hospital activity. So this is what I call double bubble. If you're made sick by something that already counts to GDP, a production of a product, a bad business practice, and you go to hospital, that operation, that activity is counted again towards GDP, and it's counted more by the UK than any other advanced economy. We have a stronger focus on NHS activity in our measure of GDP than any other. And so your illness counts twice. In turn, that's the third thing, is it disincentivizes any form of regulation or intervention that you can possibly imagine. This isn't just kind of suspicion about how the policy landscape has gone. There is now evidence in full review that policy on obesity in the last 40 years has disproportionately weighted itself towards personal responsibility, and where it hasn't talked about personal responsibility, it has framed itself in a way that makes it impossible or near impossible to implement. It hasn't come with measures, it hasn't come with time-limited goals. We can see it today, can't we? The first thing that's been put at risk by the political pressure on the Prime Minister has been the health-positive obesity strategy that was published in July 2020. That's the thing that's been sacrificed through to the backbenchers as part of the kind of save big dog operation. So we see that actually the things that are in the interest of our health don't happen, but there's a big, big incentive to those things that aren't necessarily good for our health. So this brings us, I think, to the second thing that we need to do, because we can't just have a universal public health service and allow for exploitative behaviours to continue, for our health to be made worse by business activities when we're talking about huge government investment in universal health provision. And so the idea that we can talk about in terms of the economy, I think, is a fundamental shift in whether it is possible for capital to make profit at the expense of good health. And so here I talk about public health net zero. And public health net zero would be a fundamental target, a change in how we prioritise things within the state, within the society, within the economy, towards recalibrating towards good health. Public health net zero would describe a state where it becomes impossible for health exploitation to happen in the interest of capital at the expense of people. There are three ways that you can do that. One, you can use tax to achieve public health net zero. The sugary drinks industry levy is one of the most successful policies that we've seen, and a conservative policy, a conservative government policy. But it is far too small, it's far too lacking in scale to fundamentally change the kind of nature of the relationship that we have to health and that capital has to health. So a fundamental expansion in the use of levies, in the use of tax, to make it much more difficult for manufacturers and businesses to exploit health feels like a very proportionate first step. The really interesting thing there is that taxes have been shown to increase the value of the businesses that they impact. So businesses that are hit by health taxes increase in value. They become stronger businesses. They innovate. They become more future-proof. So this isn't an anti-business policy. It's a pro-business policy. It's also a pro-health policy. The second element that you can use is regulation. And we know that there are many, many instances where more expansive regulation are possible in terms of prohibiting practices or making it much harder to do things that are negative, exploitative. The third is public ownership. And I talk about these in terms of, I think, public ownership or other forms of ownership are a good resort where we have new threats, things that we don't know about yet, or sticky problems, things that we haven't been able to rectify in other ways. But if we look at Sweden, their use of alcohol monopoly is fantastic. It creates revenue for the state, it improves health, and it's incredibly popular with the people that use it. People of Sweden love the alcohol monopoly that they have there. And the popularity of that compared to polling British people in terms of trust for alcohol companies, fundamentally different. So there's an opportunity there to raise revenue for state to fund some of the universal services I've been talking about, but also to improve health. So some really nice intersections that can help us deliver public health net zero and do so in a way that feels relatively sensible in terms of the implications. I suppose the third story is more about lived experience, and it's about our approach to social care. And during the book, I interviewed someone called Jenny, and Jenny had been a social care worker. She'd moved to London and needed a job. She'd worked in social care in Exeter before coming to London. And she described to me some alarming elements of the social care system as it exists today. She talked about her own experience in terms of being part of the workforce. So the kinds of pay and training that she received. She wasn't paid to travel at that point. There's since been legal cases won against that practice. But where she wasn't giving the training for the experiences she needed, and the worst instance of this was Jenny turned up, and I've changed Jenny's name, at a house in North London and walked in not knowing who the person was. She was covering a shift, to find someone that didn't speak English. She didn't speak the person's language, with dementia, in a lot of fear, in a lot of distress, with fundamentally no capacity to do anything about that. And I think that story, when I heard it, gets to the very heart of some of the problems that we experience and how we look at social care as distinct from healthcare today. It shows the kind of problems that we have in terms of the approach to the workforce, who in other countries are considered fundamentally skilled workers who are paid far better, who are qualified to a higher degree. And it shows the kind of problems that exist in terms of our attitudes to people who draw on care. We are currently plagued by a care system that still uses 15-minute appointments as standard practice in domiciliary care, so people's care at home, and where care homes are subject to a practice that we might call warehousing, so where people are put in rooms, taken out maybe of the visibility of society, but there's no capacity in that system for a flourishing life, for a good life, to enable people who, let's face it, we're all living longer, to live brilliant lives at the end of their life. But of course, this is a problem for disabled people as well. So we need a fundamental reconsideration, and this is actually where there have been ideas from the progressive wing in terms of new thinking. The big idea, as per the 2019 Labour manifesto commitment, the Scottish National Party have done it themselves in Scotland, is the National Care Service. And I think there's much to welcome in the National Care Service in its acceptance of universality and the NHS's principle free at the point of need. So universal and free, brilliant things to have at the heart of the social care settlement. But there's also a fundamental problem, and that is that universal social care, as described so far, the National Care Service, has no consideration for the kinds of care that are provided. And what I think we can't accept is a system of care that just makes this very low quality of care that we have available to us today more accessible. If you were thinking about mental health in Victorian England, you'd probably come across the asylum system. And as we now know, or now have consensus, that was a fundamentally unsuitable way to approach care. It was designed to take people and hide them from society. It was for the convenience of everyone else, not for the care of the people that use them. And that's somewhat the system that we have in social care today, an asylum-style system that is for the convenience of people who don't want to provide care, but not for the empowerment, the enablement of people who draw on it. And so we need a much better consideration, I think, within the National Care Service around what quality care looks like. And there are brilliant, brilliant case studies out there of what good looks like that we can harness and bring into that vision if we look for them. We can look to the cooperative models of care being run in Yorkshire, equal care, platform care, fantastic models that, because of their cooperative nature, put power towards the carers and towards those that draw on care in a way that much more large-scale, profit-orientated firms demonstrably do not. We can look to the Netherlands and the dementia villages that are there that go as far as to recreate the conditions and the kind of lives that people had before. They create new towns that replicate people's lives in a way to provide that empowerment, in that way to provide personalisation of care. And so the third part of the frontier, or the fourth if we count Revitalise the NHS, is combining that national care service with a much, much stronger consideration of what high quality social care looks like. The last story I'll tell, if I still have hopefully time, is a story about an instance in Siberia in the last decade. And what happened in Siberia was an outbreak, a strange outbreak of anthrax that has now been traced back to the melting in Siberia of the ice that had been frozen for hundreds, thousands of years, but with climate change and the advancing heat of the world had seen pathogens that have been preserved in the ice released into the human population there. It was an alarming story about the intersection between what I call the rising global health vulnerability that we face today and climate change. And the truth is that COVID-19 is not once in a lifetime. COVID-19 style events can now be expected for a child born today twice on average in a lifetime. 2 more COVID-19 style events in the 90, 100 years we might expect that person to live. This disruption repeated twice, not to mention any impact of specifically climate or financial crises that they might face. It's a huge deterioration in terms of the stability and security that children born in the UK can now expect. And it could go as far, given that we have stagnating and in some places declining life expectancy, to combine with other problems like climate change, like the rise of chronic and multiple conditions, to mean that we face a generation of children who, for the first time in essentially modern medical history, live shorter lives than their parents. So we can think about the intersections of climate change and global health vulnerability, right? We can see global trade, global travel, CO2 emissions, the loss of habitats. These are all things that make not just climate change more likely, not just global warming, not just nature emergency and lack of biodiversity, but pandemics more likely, because they facilitate the spread of pathogens from, in many cases, animals to humans. And that trend had been predicted. We could have seen that. And the massive, we've all become aware of exponential curves, the exponential rise and the risk of pandemic threat. Long before COVID-19, in fact, in 2019, Peter Sands, the well-known banker, wrote a white paper predicting pandemics and writing that we weren't prepared to face them. We could have seen that threat coming, but we haven't. The point is, we now face that same predicament again. Will we see the threat of global health vulnerability before it's too late to intervene, or will we wait once again for a crisis to happen? Now, the worst decision would be, I think, to do what the government are currently doing and to focus on security. So the insulation of the United Kingdom from the risk of pandemics. We're not worried, it seems to say, about pandemics that might occur elsewhere. We're not worried about prevention, but in fact we're worried about whether we can insulate the UK as a country that's relatively advanced, that can insulate itself from the consequences instead of that bigger prevention and global justice question. It's a replication of the kind of approach that's seen us prioritise vaccines for ourselves instead of global vaccination efforts, that kind of short-sightedness. And of course it will only be harmful, but it might in the short term be slightly cheaper. I think the next worse approach to this would be to do what might be the instinct of the NHS centrism that I talked about earlier, and to focus solely on NHS capacity, as if to say, we'll be prepared once people get sick from these diseases, but again, won't do anything to prevent them. The shift that we need to see is really in conceptualization. we need to see a fundamental change in how we think about global public health, away from the kind of security measures that proved so limited, so problematic before COVID-19. The UK was ranked second in the world for security against pandemics, for pandemic preparedness. And we've all seen the experience that that facilitated. I think in our reconceptualization, we need to be much more cognizant of that interaction between climate and the global planetary health that's deteriorating, and global public health, and that kind of widening vulnerability. So that ties together in terms of the ideas we might think about. The Green New Deal. It brings in scope the financial system that enables the kind of deterioration of planet and public health that we've seen. It brings in scope, kind of a fundamental focus on the redistribution of pandemic preparedness in terms of resources, so that we no longer see a situation where the vast majority of resources in terms of disease surveillance and prediction fall in the UK, a country where outbreaks as a source are very unlikely, to countries where we know there are high likelihoods of new disease outbreaks coming forward in the future. So I think that kind of shift to long-term thinking is fundamentally the other move that we can make. And that gives us 5 as a blueprint. The first, a revitalisation of the NHS. Very important, but in many cases maybe what we don't need the most discourse on. That seems to have been covered by most political parties. 2, a universal public health offer that talks about prevention and prevention of need, that expands Bevan's work to social policy, not just medical. 3rd, a public health net zero that prevents need at source and kind of targets the practices that create need in the first place. 4th, the revitalisation of social care in terms of thinking about quality, not just universality. And 5th, preparation for a long-term reality that our health has now become a major source of existential threat for all of us in this country, but also globally. So I will pause there, and hopefully we have some time still for some questions, but looking forward to them.
Thank you very much. It's brilliant.